Welcome to AETCM, the emergency medicine channel. So we know we are starting the gastrointestinal series we are following. In that we started upper GI bleed. From that today we are going to discuss regarding the peptic ulcer disease. So this is our content: introduction, causes, and then pathophysiology, assessment, what are things we have to keep in mind, management, and then finally complication. So this presentation will be little more elaborate in manner. So because it is the most common condition, we have to lifestyle wise how we have to manage, and then what are the advice we have to give to the person, and then surgically what are the surgical management is there, and then how the clinical manifestation. So little bit compare with another presentation. In this presentation we are going to deal little bit elaborate manner. Okay. So first thing, what is the definition of peptic ulcer disease? So as usual, anyway, every presentation will say the name itself will segregate and then will define, right. So peptic ulcer disease, pep or PUD. What is meant by peptic ulcer disease? First one will define ulcer. What is meant by ulcer? Ulcer means there will be a breakage or there will be a breach in the continuity of the tissue or layer, that is called the ulcer, right. So here peptic means that is referring pepsin. Okay. So here the ulcer will form because of the digestive action of pepsin or pepsin and the stomach acid, that is called the peptic ulcer. Okay. So I think it will be clear statement. Ulcer means there will be a breakage or there will be a breach in the continuity of the cell or layer, that is called the ulcer. Why this ulcer happening in the GI tract means because of the digestive action of pepsin and then stomach acid. Stomach acid in the sense that is our hydrochloric acid. So that is called the, if you are combining everything means that is called the peptic ulcer disease. Again the same thing definition only we here we given. The mainly where the breach will occur means, or where the breakage will occur means the mucosal layer. So the previous presentation itself we told the walls or the layers in the gastrointestinal tract. First we have a mucosal layer, followed by we have a submucosa, followed by we have a muscular layer, and then outermost portion is a serosa layer, right. So the mainly that breach or breakage will happen in the mucosal layer. So again peptic ulcer can occur in anywhere, either it may occur in the esophagus or it can occur in the stomach, or it can occur in the duodenum also. So another term is there like esophago-gastro-duodenal ulcer, there is a other term also is there. So that way it can occur esophagus. Esophagus means mainly because of the reflex. So whatever content that is in the stomach, that will reflex or revert back into the esophagus, and then thereby it will cause the peptic ulcer. So again GERT also upcoming presentation we are going to discuss, and then it can occur in the stomach or it can occur in the duodenum also. So before that, so little bit we have to know regarding the anatomy of the mucosa and then anatomy of the secretion related things. So how the we told digestive action of pepsin, right. So how the pepsin will affect the our mucosal layer, or how the our peptic ulcer disease is happening. So this is or consider this is our esophagus and then stomach. Okay. Please consider this one as a stomach, and then here we have this up to this is a esophagus, here we have a cardiac sphincters, and then this is our upper portion, this is our body, this is our antrum, right. This is antrum, and then here we have a pyloric sphincter, this is a fundus, this is our body of the stomach, right. So here in body of stomach we have a two major cells. One is called the parietal cell, one is called the chief cell. Okay. This parietal cell will secrete the two major factors. So parietal cell it will secrete the two factors, that is our HCl, stomach acid, and then our intrinsic factor. Okay, intrinsic factor. So whenever you get a stimulation from the nervous system, mainly by the vagus nerve, So it will act on the parietal system. There you have some receptor like H2 receptor, histamine receptor. It will attach, the nerve signal will attach to the H2 receptor. Thereby your parietal cell will secrete the stomach acid, that is HCl, and then intrinsic factor. And then second thing, here we have another cell that is called the chief cell, CHIEF, chief cell. This is called this chief cell will secrete the one substance that is called the pepsinogen. Okay. Pepsinogen is a inactive form. So inactive form. If it want to in an active form means, then it want to convert into the pepsin. Pepsin is an active form, pepsinogen is an inactive form. So what the HCl will do means, this HCl will take part this pepsinogen to pepsin conversion mechanism. It will activate the pepsinogen into the pepsin part. That is the action of the HCl. This intrinsic factor mainly that will take a role in the protein metabolism. That is a factor of the protein metabolism. So to understand our PUD, peptic ulcer disease, we have to know about these two things. To understand the disease, mean the same time to understand our management also. So first remember, we have a parietal cell that is secreting your HCl and then intrinsic factor, and then we have a chief cell that is secreting pepsinogen. This pepsin and then this HCl only causing our peptic ulcer disease. Okay. So still we have a still more, this is G cell we have, and then we have a mucosal cell. So those are the things that will secrete the defensive factors like a mucus that will secrete one mucus coating. So that mucus coating will cover all over your stomach, and then that only prevent your acid action in the that will neutralize or that will prevent the erosion of your acid from acid. Okay, that is the action of the mucus and then other substance. So this is what this is the other form of ulcer, or we have a peptic ulcer disease, we have a 2-3 different forms of ulcer. First thing called the Curling's ulcer. Curling's ulcer mainly will occur in the severe burns cases. In severe burns, what will happen? Mainly in the burns, your fluid level will goes down, right? The fluid shift will happen, and then the body will lost large amount of fluid. Because if the fluid will level goes down, means what will happen? Your plasma fluid level will decrease. Plasma fluid level decrease means what will happen? Or viscosity of the blood will increase. So the viscosity of the blood will increase. If the viscosity of the blood will increase means what will happen? Your circulation flow, your blood flow won't be there. So it will affect your blood flow. If the blood flow affected means what will happen to the particular tissue? It will cause ischemia. If the ischemia prolongs means that will cause your necrosis. So this necrosis and then ischemia will cause the slugging of gastric mucosa, ultimately it leads to the ulcer. This is called the Curling's ulcer, mainly will occur in the severe burns cases because of the fluid loss. Okay. And then second, in another one more form is there, that is called the Cushing's ulcer, Cushind, Cushing's ulcer. Mainly it will occur because of the any head injury, or because of any increased intracranial pressure, or because of any brain tumors. That case, that will one form of ulcer will form, that is called the Cushing's ulcer. Okay. So you can remember by the Cushing triad. In increased intracranial pressure, we have one triad, right? Cushing triad. But the same thing only here, the ulcer formation will be there because of the increased intracranial pressure, that is called the Cushing ulcer. And then this is the image of the normal mucosa, and then here you can see the some erosion because of the peptic ulcer disease. And then coming into pathophysiology, usually in our gastric content, the gastric content pH will be somewhat 1 to 3. Okay, our gastric content pH is somewhat 1 to 3. With this pH, that will easily erode whichever tissues. So that is that much of acidic nature. That is why we have in body itself we have some defensive factors. So, there also we told some G cell and then we have some mucus secreting cells. So, they will secrete some bicarbonate, prostaglandins, mucus layers. This we have in our gastric system, we have some epithelial cells, that the renewal of epithelial cells, mucosal blood flow. These are the some defensive factor that will defend from this pH or this pepsin activity or hydrochloric activity. So, whenever there is an imbalance between the aggressive and the defensive factor, aggressive factor means the HCl level will increase or your pepsin level will increase. In the case of Helicobacter pylori bacteria, that is one of the bacteria, and then because of use of NSAIDs, pepsins, bile acids, smoking, alcohol, in this case either that will increase the HCl acid or they may decrease the your defensive factors. In this case, the imbalance case, the peptic ulcer disease will occur. This is the reason for the peptic ulcer disease. And then coming into causes, mainly lifestyle causes, smoking, acidic drinks and then medications like NSAIDs. And then age wise, the incidence wise, we told the ulcer can occur in the stomach or there may be a possibility in the duodenum also. So, based on the incident report, duodenal ulcer mainly it will occur in the 30 to 40 years, gastric ulcer more than 50 years, gender wise increased risk for the older woman cases, other causes like caffeine, cold, spicy food, stress also causes for the peptic ulcer disease. So, again other important major important one microorganism is that is called the H. pylori or Helicobacter pylori. So, Helicobacter pylori is one of the bacteria that will present in our gut and then our stomach. So, we told in our gastric content our pH will be somewhat 1, 2, 3. With this pH easily it will erode or easily it will kill whichever bacteria, but how the H. pylori bacteria survive even with this pH, that is the one of the concept you have to understand. The H. pylori, what he will do, he will secrete one enzyme that is called urease. So, this urease what it will do, even so in our body normally we have a urea, right, so urea one of the substance. So, it will convert the urea into ammonia plus your bicarbonate. Okay. So, it will convert urea into ammonia plus bicarbonate. So, this ammonia and bicarbonate is basically these are the base substance. So, this base substance that will neutralize your acidic nature. So, here acid is more, here mean the same times the same side you have a base substance. So, thereby it will equalize the acidic nature, easily it will survive, the H. pylori bacteria will survive. So, what is the drawback or what is the consequences problem will arise means this ammonia, right, this ammonia will damage our mucosal cell. So, that is the one of the major complication or one of the major problem with the H. pylori. So, this ammonia will erode or it will affect or mucosal tissue, that will occur in the H. pylori cases. So, management strategy in H. pylori wise, we have to treat the peptic ulcer, mean the same time we have to treat this H. pylori infection also, we have to kill the H. pylori bacteria also. So, and then coming into assessment part, mainly in peptic ulcer disease, pain is a major important thing. So, for pain we have to follow the OPQRST mnemonic, and then in assessment point or clinical feature the person will feel a pain, the nature of the pain will be sharp, aching, burning, gnawing and then pain, weight loss will be there, melena will be there, hematoxysia will be there and then fatigue, bloating, hematemesis also will be there, burping, nausea, anorexia, vomiting wise, mainly in a gastric ulcer if the person vomited means they will feel some relief. In gastric ulcer, not in a duodenal ulcer, if the person have a gastric ulcer, if the person vomited means because of that vomiting that whatever gastric content that will evacuate, right. So, for that the person may feel some relief. So, constipation also accounted for the 5% of the patient with a chronic duodenal ulcer. So, tenderness also will be there and then in if it is a gastric ulcer means mainly epigastric region left to the midline. If it is a duodenal means right to the midline, the person may feel the pain or tenderness. So, then this is the difference between the gastric and the duodenal ulcer. So, this is fully based on the assessment related thing. How we can differentiate the gastric and duodenal ulcer by the assessment itself. First thing, these two things regarding the incidence. So, majorly age wise the gastric duodenal ulcer between the 50 to 60, duodenal ulcer 20 to 50. It is not exact one, there is one of the risk factor, okay, based on the incidental report. In male and female ratio, majorly in a gastric ulcer almost equal, whomever it can affect. Duodenal ulcer, male are more prone compared with an female. And then pain, so where the pain will feel, in a gastric ulcer, epigastric region left to the midline, duodenal ulcer right to the midline, because the anatomical location of the organ. And then radiation of the pain, in gastric ulcer there won't be any radiation, duodenal also majoritarily it won't radiate, but some rather time it may radiate to the back. So, this radiation of the pain is one of the most important thing we have to know, because epigastric pain some rather time that will misdiagnosed as a myocardial infarction or myocardial ischemia or acute coronary syndrome, right. In acute coronary syndrome also sometime the person may have a pain in the upper chest or in the middle of the chest or left side toward the left, or the person may have a epigastric region. This is a confusing factor. Here you can ask about the radiation of the pain. In ACS we have in ischemia or infarction we have a radiation of the pain to the left shoulder, right, but here there won't be any radiation or that might radiate to the back only. So, this is one assessment point we have to keep in mind. And the nature of the pain, both will be in a periodical nature. When it will occur means, so mainly in gastric ulcer immediately after food. So, immediately after food what will happen, your gastric acid will secrete, so that will irritate your ulcer region, thereby it will produce a pain. But duodenal ulcer, it will occur only 1 to 2 hours after the food. Why means, so 1 to 2 hours, so after that only your food will move from the gastric part to duodenal part. So, whenever your food material reaches the duodenal part, then only it will irritate the mucosa, then only the person may feel the pain. That is why duodenal ulcer 1 to 2 hours after the food, but gastric ulcer immediately or within 30 minutes to after having a food. And then weight loss, majorly in gastric ulcer it will present due to reduced intake. So, whenever the person taking food, they may feel the pain, the provocation of the pain or the intensity of the pain will increase it. Because of that panic he won't take food, for that reason the person may reduce the weight, but duodenal ways there won't be any problem in the weight loss. Hemorrhages, any bleeding related, mainly gastric ulcer the person will develop the hematemesis, but duodenal ulcer there will be a melena. And then gastric symptom, in that gastric ulcer, sensation of feeling fullness, indigestion, heartburn, gas troubles, and then belching will be there. But in the case of duodenal ulcer, the person may feeling the bloating feeling only because of the gas. And then malignancy, gastric ulcer there is a increased chance, there is a higher chance, but in the duodenal ulcer there will be a less chance. And then finally there is some palliative factor, relieving factor, that is for gastric ulcer if you vomit the or if you have a alkali food, that will subside or that will reduce the intensity of pain, but duodenal ulcer if you take the food for first 1 to 2 hours, the person may feel the reduced pain. So, this is the ameliorative or palliative factor. And then coming into final part, that is your management. So, lifestyle management, pharmacological management, surgical management. Before that, in pre-hospital, what is the major two goal we have to manage with? First one is the pain, second one is your volume resuscitation. So, majorly volume resuscitation because of the hemorrhage. If the person have a major amount or severe dehydration, if the person lost more amount of blood means, then you have to think about the volume resuscitation. The most important thing is the pain management, and then we have to rule out whether that is because of the pain is the reason for the pain, the cause for the pain. whether that is because of PUD, peptic ulcer disease, or else the other factors like ACS is there or not, that we have to rule it in the scene itself. These are the 3 factors we have to do in the pre-hospital scenario. So, first we will see the lifestyle modification. What are the advice you have to give the person? The person, we have to ask them to avoid NSAIDs, caffeine, smoking. These are the risk factor, right? So, the garbage, the dietary instruction wise, garbage juice we can advise them, and then fiber rich diet in the duodenal ulcer cases, that will helpful for the, because that fiber rich diet, it will take a long time to the digest. So, it will stay in the gastric part for a long time. For that reason we can advise them, and then garlic also it have a anti-helicobacter activity. Coming into pharmacological management, so we told pain is a major important thing, here we have to manage, right. So, pain, so what is the reason for the pain? The pain is occurring because of the HCl plus pepsin. Okay, because of the pepsin HCl only, they are going to irritate the ulcer area, or they are irritating the mucosal area, thereby only you are getting the pain. So, what our action should be? We have to manage this HCl and then pepsin. So, if you want to manage the pepsin, means easily you have to think about the HCl alone, because we told HCl is one of the factor that is only converting pepsinogen to pepsin. So, if you control the HCl itself, thereby we can reduce the activity of pepsin. So, how we can manage the HCl? Either you have to reduce the secretion of HCl, or you have to neutralize the HCl secretion. Already some amount of secreted means, then you have to neutralize the secretion, or you have to reduce the HCl secretion. This is the 2 step of management only we have. So, to reduce the secretion, how we can do? Either we can go with an H2 receptor blockers, or we can go with an proton pump inhibitor, anti-muscarinic drugs, or else already amount of secreted means, there you can go with some antacids or neutralizing agents, that is your sucralfate, sodium bicarbonate, those are the some set of management. And then some antibiotic also we are using for the case of H. pylori induced PUD. We will see one by one. First one is a H2 receptor blockers. So, what is the action of H2 receptor blockers? It will block the H2 receptor found on the parietal cell of the stomach. So, you just recall that anatomy what we discussed is earlier. So, parietal cell, here we have a H2 receptor, there everything will attach, and then thereby it will produce your HCl, right. So, it will block the H2 receptor, thereby your parietal cell won't respond to anything. So, the gastric acid automatically it will reduce. So, the drug wise, ranitidine, nisatidine, and then cimetidine, these are the drugs we have. Second category, that is a proton pump inhibitor. The same action only, it will act on the parietal cell, it have a anti-secretory, it is a more potent anti-secretory drug. Say the same thing, it will act on the your parietal cell, thereby it will block the your proton pump. So, thereby it will reduce the secretion. The drugs wise we have omeprazole and then pantoprazole. So, third category anti-secretory is a muscarinic antagonist. So, muscarinic antagonist means, so we aware about the muscarinic nicotinic receptor, right. So, mainly the antagonist means it will act against the receptor. So, that is called the antagonist. So, it have a anticholinergic effect. So, the drugs wise we have a pyranozepine and then telanzepine. And then other side, so first we try to reduce the secretion, or else we can go with a neutralizing, that is called antacids. So, antacids, these are the majorly base substance, it will increase the pH of your gastric content, straight away it will increase your gastric pH. So, what will happen because of the increased pH means, mainly your peptic activity get reduced once the peptic activity get reduced. Why means, the if the pepsin want to in an active state means, it need a less than pH 4. So, whenever you are giving base substance, it will increase your pH, thereby your pepsin activity will reduce. That is the reason, or that is the action of your antacids. So, mainly we have two various route for administration. First one is you can administer through the systemic or perioral route. or you can straight away you can go with an parenteral route, that is your IV route. Okay. So, peroral route we have a aluminum hydroxide and then magnesium hydroxide. Systemic wise you have a soda bicarbonate or sodium bicarbonate. How the sodium bicarbonate will act on this system means, sodium bicarbonate NaHCO3, right, it will attach with your HCl, okay, thereby it will produce water H2O plus carbon dioxide CO2, remaining factor is a CO2 plus your sodium chloride, okay. So, thereby it will reduce the soda bicarbonate or sodium bicarbonate will attach your hydrochloric acid, it will produce the end product, it will produce H2O plus carbon dioxide plus sodium chloride. The inactivate, it will inactivate the every activity, thereby it will manage your neutralize your acid level. And then final one is a H. pylori eradication therapy. So, we told in H. pylori case we have to deal the H. pylori bacteria, mean the same time we have to treat the ulcer. For that we have a triple therapy, that is called the triple therapy. Either proton, first the component is a proton pump inhibitor along with amoxicillin or clarithromycin, or we have a combination of clarithromycin metronidazole. This is the antibiotic group. We have a first fixed component is a proton pump inhibitor. Either we have to add amoxicillin or clarithromycin, sorry, amoxicillin plus clarithromycin or clarithromycin metronidazole. This is called the triple therapy because it is a combination of 3 drugs. So, one drugs we have like a pan top, okay. And then whenever the medical management fails means, then we are moving on to the surgical management. So, the indication for surgical management, failure of medical management, development of complication, high level of gastric secretion, mean the same time the peptic ulcer disease affect both the gastric and duodenal, means where straight away we are moving on the surgical management. Approaches wise, gastroenterostomy. So, here we will create a passage between the body of the stomach to the small intestine, that is a clinical picture image we can see. And then vagotomy. So, we told vagus, there is the nerve that will carry the signals to your parietal cell, right. So, vagotomy, thereby we can dissect the vagus nerve and then eliminate the gastric acid secretion stimulation. And then third one is a andrectomy. Ectomy means removal. So, we will remove the antrum part of your stomach. And then fourth one is a Billroth 1 and then Billroth 2. Billroth 1 means we will dissect or we will cut the distal portion of your stomach and then straight away we will anastomose the remaining part of your stomach to the duodenal part, that is Billroth 1. Okay. Billroth 2 means the lower or distal portion of the stomach anastomosed with the your jejunum part, that is called the Billroth 2. Finally, complication, bleeding is one of the thing, and then coffee ground vomiters and then occult blood in the tarry stones, that is called your melena. And then perforation also one of the. So, if the thing is if the gastric ulcer is prolonging for longer time means it will erode the whole wall and then it will cause the perforation. Gastric outlet obstruction, it can narrow the pyloric sphincters. Post-op complication like a dumping syndrome, malabsorption, duodenal stump leak. Dumping syndrome means rapid evacuation of gastric content. So, whatever content that is in the stomach part, that will rapidly evacuate to the duodenal or to the intestinal part, that is called the dumping syndrome. Malabsorption, duodenal stump leak also one of the complications. So, do your best. Shalom.